Hi, and welcome to the Dr. Coffee Podcast, your weekly blend of motivation, encouragement, education, and insight into all things medicine for junior doctors and medical students in South Africa. Welcome to episode 12. Okay, so in this week's Coffee with Consultants feature, we're going off brand a bit and interviewing a registrar in our featured specialty rather than a consultant. Nonetheless, this week's episode features a surgical specialty that so many of you, the Dr. Coffee audience, have requested that I simply could not wait for an opening with a consultant. And so I'm very pleased to introduce our guest for this week's episode, which is all about the path to specialising in paediatric surgery. Dr. Jason Mcmaster is currently a registrar in paediatric surgery at the Nelson Mandela Children's Hospital in South Africa. After completing his internship and community service years, Dr. McMaster held a medical officer post in the pediatric burns unit at Hani Baragwanath Academic Hospital, where he discovered his calling and passion in life. It was a great privilege to interview Dr. McMaster for this podcast, and I'm sure you'll find the interview extremely interesting. Before we dive into the content of today's episode, I'd like to give a special mention to the sponsors of the Dr. Coffee Podcast. Our first sponsor on the Dr. Coffee Podcast, I'm pleased to introduce you to FlashMed. FlashMed is a new type of medical study flashcards pre-packaged and formatted to assist you to be more effective as a student and ultimately help you to become a better doctor. Comprising pharmacology revision flashcards, clerking sheets, muscle anatomy flashcards, and revision notes, amongst others, FlashMed products are printed using the highest quality paper, and each set consists of 50 flashcards or pages. You can find FlashMed on Instagram at @FlashMedSA and order direct from them via DM with nationwide delivery. For this and other episodes, I'm also pleased and proud to announce our partnership with WardWorks. WardWorks is a free patient list and task management app that allows doctors to simplify the way they work. Join the hundreds, if not thousands, of South African doctors who are using WardWorks to keep track of and easily access patients' information, location, and ward work. There's a reason that more than 250,000 tasks have been completed using WardWorks in less than 2 years. WardWorks is a web-based app that can be accessed through your internet browser on mobile or desktop simply by visiting wardworks.app. But most convenient of all is to find the downloadable applications on the Apple App Store and Google Play Store. You'll also find some very useful perks to using WardWorks, that's PERX, such as discounts on scrubs and stethoscopes and other cool stuff that makes being a dogger that much more rewarding. Thank you to our sponsors, and now back to today's featured specialty, pediatric surgery. Whether you've had any exposure to pediatric surgery or PedSurg in your studies or working career or not, it should please you to know that the training available to surgeons in South Africa who wish to specialize in PedSurg is excellent and compares favorably with high-income countries who often send their surgeons to South Africa to further their skills. Listening to Dr. McMaster, it was encouraging and motivating to learn just how highly esteemed the South African clinical setting is regarded by the world. We would do well to appreciate the opportunities we get as junior doctors and medical students, even amongst our challenges. I'm excited for you to hear this week's podcast, and so without further ado, here is Dr. Jason Mcmaster. Welcome to the Dr. Coffee Podcast, Dr. Jason Mcmaster.
Thank you very much. I'm very happy to be here today.
It's wonderful to have you as a guest on the program. Our audience have been requesting ped surgery. Trauma surgery was one of our more popular episodes, so it seems that there's a definite hunger for surgeons on the podcast. And after a slew of physicians, I'm sure they'll be very relieved to have another surgeon on. So thank you so much for making yourself available and for your time this fine afternoon.
Cool.
We're here at the wonderful Nelson Mandela Children's Hospital in Parktown. And with all of our guests, the first question that I'd like to ask is how and where you did your medical training and your junior doctor years. So let's start where you went to med school.
So I was in Cape Town. I went to UCT. It was a very good 6 years, extremely rewarding. I learned a lot and had a lot of fun as well. And for my internship years, I went to Barrow. There were a bunch of us at UCT who all came up together. Barrow has like this myth in Cape Town and maybe elsewhere as well, of being like this jungle, and if you can make it at Barrow, you can make it anywhere. And I think there are a few of us who are excited by the challenge of going to the terrible city of Joburg, as all Cape Townians think, and taking on the challenge of being an intern at Bara. And it was a good time, a difficult time, as I'm sure every Bara intern will attest to. But yeah, overall, I'd say it was a good 2 years.
So you alluded to a little bit of a myth around Bara. Can you maybe just expound on that a bit? So what I want to ask is, what had you heard about Bara that was true, and what had you heard about Bara that was a complete fabrication?
Sure. So at UCT, at least, Bara has this reputation of being, like this jungle of a hospital that is crazy busy, that'll push you more than anywhere else, and all that is true. In my 2 years, I found Bara to be a jungle that pushes you like you thought you couldn't be pushed before. So that was all accurate. There's also kind of a myth of it being quite tough, being quite difficult, like physically in terms of calls and mentally as in terms of like coping with the workload. And that is also true. It's a tough place to work, especially as a junior doctor, but it is good. When I've chatted to kind of students who've been looking at places of doing internship prior to this, I generally say, like, in my opinion, 8 out of 10 interns at Bara come out of the experience having like grown a lot, having really enjoyed it, having learned a huge amount about medicine and about yourself, as you can only do in like really tough circumstances, and they would do it again. Wow. But that being said, that's 2 out of 10 who, for those people, it was a traumatic experience. It wasn't worth the time. And I think for any person, when you make these kind of decisions, you have to be honest with yourself. And it's not acknowledging weakness, it's just acknowledging difference in character. Some people can like really thrive and enjoy being pushed perhaps too far, but for some people, too far is too far. So it's a great time, but I think you need to go into it with open eyes.
Okay, so completed your 2 years of internship at Bara.
Yeah.
What was your enduring memory of Bara? Like, what was your outstanding lesson that you learned at Bara, if I can ask?
Oh man, so many over the 2 years. The one that I come back to, because it oftentimes gets me through a difficult call, is not to trust yourself after midnight. Not to trust your thoughts after midnight, because your mind goes to dark places. And there's actually a really interesting paper published on mental health after midnight. And you have really terrible thoughts. And one thing sticks out to me. My first rotation was surgery as an intern, and I was in trauma, and it still is. It's a crazy, crazy place, and you learn a lot, but man, you are pushed like never before. And it was 3 a.m., it was a weekend, and I was wheeling a drunk, assaulted patient to CT scan at like 3 a.m. And I remember thinking to myself, like, I am becoming a radiation oncologist. They make the most money and they spend the least amount of time at work possible. That is what I am doing. I woke up like after the hour nap that I had, and it was the next day, and the sun always comes up.
Every call has a finish.
Exactly. Every call ends, the sun always rises. I thought to myself, like, how stupid. You hate anything related to radiation oncology. Carry on, And that was one of the biggest things. Don't trust yourself after midnight.
Wow.
You're gonna have bad thoughts. Just learn to ignore it and carry on. It has been helpful in giving that advice to my wife with our kids when it's 1 a.m. and she's up again and she's having terrible thoughts about how terrible it is to be a parent. Don't trust yourself after midnight. In the morning, the sun comes up. And you'll regret the thoughts you had.
I love that, because it has broad application to anything. Even a medical student listening now, thinking how rotten their life is because they're studying for an exam. It's like, don't trust your thoughts after midnight. I love that. Okay, so internship, and then did you stay on at Bara or did you go further afield?
No, I went closer to home. We lived in Melville, and I did my ComServe at Helen Joseph Hospital. So by this point in my career, I was married. I got married in my first year of internship, my wife's job was in Joburg, her entire family was in Joburg, so we did our best, and we bought a house in Joburg. So
I love that she's been available or a part of the ride for all of your junior years. So she's seen you through all of these times.
Oh, yeah, you should interview her. She'd probably give you a more accurate idea of how my medical career has gone than I would. I have rose-colored glasses to anything medicine. Yeah. It helps helps sometimes. And
Does she ever tell you to stop talking about medicine when you get home?
No, thankfully she doesn't. We'll chat about it later, but we have a rule that when I'm at home, I'm a husband and a dad, unless obviously I'm studying or doing any work, and when I'm at work, I'm a doctor.
Okay, so Helen, was Helen a place that you chose specifically?
Yeah, so
for
I put
the
it as
location?
first choice. I was like, we lived in Melville, and it was right down the road, and I wanted a change of scenery after Barra. And so Helen, I had heard good things about Helen Joseph Hospital, so thankfully I put it as first choice, and provided the deed on my house to say this is why I want to stay in Barra, and the Department of Health listened, and I was placed at Barra for my ComServe, which was a good 2 years. The entire period was spent in the emergency department. My first 6 months were there, and I was due to go to internal medicine, and something deep within me really loathed the thought of going and doing internal medicine for 6 months. So I managed to swap with someone very unlucky who went internal medicine for 6 months, and I got to stay in the ED. The Helen Joseph Emergency Department was and still is a very, very good emergency department. And again, I learned a massive amount during that time. Again, hard work. Anyone who's ever worked there knows the nights are long, the calls are long. There's a lot of responsibility, even for a ComServe, in that emergency department.
And yet you mentioned that you had heard some great things about Helen. What were some of those things? So for my mind, I've heard good things about the surgical department.
Yeah.
So I don't know if maybe you had already had in your heart that surgery was where you wanted to go.
Not at this point. I think I'd heard good things about almost all the departments. And I still really wasn't sure. I was interested in surgery, and I was interested in like a career in treating kids. Obviously, Rahima Musa and Helen Joseph can be paired. But it was like also a marriage of convenience. It was in Joburg, it was close to home, and the departments that I'd heard about were good.
Okay.
Yeah.
So you said you did 2 years of community service, so I assume that there was some...
No. I did 1 year community service, split into 6-month blocks.
Okay, so not extra time at Helen Joseph.
No. Thankfully, not extra time at Helen Joseph. So, normally you have an experience of 2 departments at Helen Joseph at 6 months each. So I opted to stay on in mine, so I got a year of emergency department time. And like I said, it was good. Like you do learn a huge amount there, like treating the undifferentiated patient. And it's a completely mixed ED. It's medical, surgical, and trauma. So the scope is huge, and you learn to become really confident with resus, really confident in treating like the undifferentiated sick patient. So for someone who was unsure of what they wanted to do, I think it was a good fit. I got to see a bit of everything and have some fun and learn a lot. And when isn't resus important when you're a doctor?
Of course.
Maybe if you're a dermatologist, but everything else.
And we've said so much on the podcast before that your exposure is so important. You oftentimes, even as a student, get to choose what exposure you get. You just stay on a little bit later or go to a specific site, and you do get exposed to various things. Now let's fast forward a little bit. So you currently are a registrar in paediatric surgery. So at what point did you make that decision that was what you wanted to do?
So Simon, there's the saying that I've heard a few pediatric surgeons say, and it's pediatric surgery chooses you. You don't choose pediatric surgery. And it's interesting, talking to a few of my colleagues, that's happened quite a lot. My story is that I was doing medical officer time in ICU. I knew I was more surgically inclined. I'd considered plastics and reconstructive surgery, but at the same time, I'd really enjoyed the exposure to kids that I had. Part of your medical officer time in ICU at Barra is spending time in the pediatric burns ICU unit. And I ended up spending a lot of time there and really enjoying it, enjoying the critical care aspect of it, but 2, enjoying working with kids, and then 3, enjoying this kind of surgery aspect of treating kids with burns. And I found myself seeing the pediatric surgeons on ward rounds and being like, man, I wish I was a part of that gang. They look so cool, And they did. Like, they carry the little boxes. I suppose I say they. No, we. Carry our little boxes with our loops in, and, and everyone knows what they look like.
Tubes of Viroxil in the pockets.
Exactly. Tubes of Viroxil in the pocket. There's one in my bag right now. And, like a slew of events over like a 2-month period made me think, well, let me see what it's like, and I applied for an MO job. There was a colleague he said to me, have you thought about pediatric surgery? I think you'd be a good fit. I remember distinctly saying to her, her name's Melissa, I said to her, Melissa, do I look like I want to work that hard? And but it stayed in my mind that Melissa says I'd be a good fit, and it just, people kept on making little comments. One of the consultants in ICU at Barra, in Peds ICU, said, you remind me a lot of someone I know who's a pediatric surgeon. All those little things happened. I thought, let me just apply. So I applied, got the job, and my first day, one of the consultants, Chris at Barra, said, welcome, how long do you plan to be with us for? And I said, I don't know. And it's, I think, 3.5 years later, and I'm still here. So
wonderful.
Yeah.
So how many years of MO time did you do before becoming a registrar?
I did exactly 2 years to the day. Started the 1st of January, and then 2 years later, 1st of January, started reg time. Yeah.
And what was the path like? What expectations did they have as you were doing your MO time? In order to become a registrar in pediatric surgery, for those who are planning a career in pediatric surgery, how many months of MO time do they need? And is there any courses that you felt, there might be some that are prerequisites, but any that you felt lent an advantage to you?
Okay. I'm going to go through what I think, if I were to go back, what the perfect path would be.
Yeah.
And then my path was quite different. So I think like the perfect path would be to do your internship, really anywhere where you think you're going to enjoy it and learn a lot. I don't think internship matters too much in your future career. In terms of ComServe, then try and select a place that has a surgery rotation. Places that often get lauded as something like a Klagstorp, where you go there as a ComServe, you rotate through surgery, and you're not just an intern working with a ComServe salary, you're actually getting involved. So I recommend doing your ComServe somewhere where you can rotate through a surgical discipline. And then from there, I'd recommend actually getting an MO job in general surgery. The thing about pediatric surgery is it used to be a general surgery fellowship. You do general surgery first,
and then 2 years
exactly
extra,
2 years extra time to become a pediatric surgeon. That changed in the mid-2000s, that it's its own speciality that requires 4 and now 5 years. But as a prerequisite to entry, you need to have general surgery intermediates. Before you even get invited to an interview for pediatric surgery, reg time, you need to have general surgery intermediates.
Because you need those skills as well. I mean, from the time that you work as a registrar, you're going to be working in surgery.
Yeah. They expect a good baseline level of surgical knowledge, intensive care knowledge. That's part of the intermediate requirements as well to get into pediatric surgery. So I think the ideal route would be MO time as a general surgery medical officer, and spending as much time as you can in theatre, getting your hands ready, kind of finding your feet in theatre and spending time cutting. The difficulty is trying to get all the points needed to write intermediates. You need 6 months of trauma time, you need 1 year of general surgery time, and you need 6 months of ICU time.
Sure.
Like the perfect place for anyone in Joburg would be somewhere like Baragwanath, where if you are a MO in surgery, they will rotate you through those units.
You'll do ICU.
Exactly.
You'll do trauma.
Within the kind of the agreement is within 2 years of MO time there, you would have rotated through enough places to be able to write intermediates. And once you have your intermediates, you'll be able to then get into pediatric surgery.
What about other surgical disciplines as a foundation? So let's say you did ComServe in obs and gynae, and you were cutting 10 Cs a night. Would that time help and count towards surgical points, or not really?
No, so it wouldn't count towards general surgery intermediate time. I mean, look, it would count for that individual, for them to know that this is where I want to go, and it would count in terms of being in theatre. So theatre is an extremely intimidating place for someone who isn't accustomed to it. And I remember going into theatre as a third year or whatever it was, and being terrified of I don't want to touch anything, I don't want to do anything wrong. The more time you spend in theatre, the more time you spend with your hands in a patient, the more comfortable you get. And whether that's an ENT, obs and gynae, plastics, whatever it may be, it's going to be helpful in the long run. In terms of actually getting objective points to write an exam, obs and gynae wouldn't count for general surgery.
Sure.
But yeah, it would still be helpful to the individual.
Okay.
So that would be my recommendation. MO time, accumulate those kind of prerequisite points to write your intermediates, write your
Yes.
intermediates, and then
Yes.
apply. The other path, which isn't better or worse, it's just different, is that we have quite a few people coming across from general surgery registrar time. So what they will do is they will do a bit of MO time in surgery. You don't need intermediates to get a general surgery registrar, you just need primaries. So they'll do their general surgery MO time for like 6 months, write general surgery primaries, apply for a registrar job in general surgery, get the job, and then within the first kind of 2 years of general surgery reg time, write their intermediates. Once they got their intermediates, they got their ticket, and then they're going to apply to pediatric surgery.
Now, I realize that I'm asking this question, and the immediate weakness is that you're not a consultant that sits on any of these boards that makes the decision. But do you have a sense of how competitive the process is for all of this that you're talking about? Because you're saying this is the ideal route.
Yes.
I imagine that there's more than one person that says, well, this is the ideal plan, this is what I'm going to do.
Yeah.
So how competitive is that road?
So like there's so many variables that go into the like competition for posts, and I think competition for posts these days is tougher than it ever has been. The general surgery registrar route I don't think is exceptionally competitive. I think if you have primaries and you have some general surgery MO time, sooner or later you're going to get a general surgery registrar job. So I think what I would recommend is start MO time in general surgery, write your primaries as soon as you can, then start applying for a registrar post. But like, don't rest on your laurels. Apply for an ICU MO post so you can get one more notch to write intermediates. And maybe before they're willing to give you a job in general surgery, you've already got all your points and you can write intermediates because you've rotated through general surgery as an MO, you've got your trauma time, you applied and rotated as an ICU MO as well. And then you say, actually, guys, I don't need this job anymore. I'm going to go straight to pediatric surgery. So in terms of competition, I don't think general surgery is very difficult. But some people have found it difficult, right? And the example I gave of getting your points as an MO, I know people have done while they've been waiting for posts, whereas other people have done ComServe surgery, written primaries, and gotten a post in general surgery registrar program straight out of ComServe. So I think the thing would be like, it doesn't hurt anyone to apply.
Sure.
Know the road you're on, have the path laid out. If you don't get accepted, but always apply, see what happens.
But you're also proof that even if you don't follow that ideal path, that there is, there's hope.
Yeah.
So no one needs to feel like they're crushed and devastated if it doesn't go according to plan, right?
No, man. And I don't think you ever crushed or devastated. There's an obs and gynae consultant in Cape Town, a wonderful woman, and she actually did 3 years of reg time in psychiatry. Decided, you know what, this isn't good for my mental health to be seeing people with this kind of mental health, and she stopped, did MO time in obs and gynae, started reg time, and graduated, and was the oldest of her graduating class. But she had made the right decision. I don't think it's ever too late, and I don't think you're ever on the wrong road. You never know. You think you're on the wrong road, and then one day, because the only job you could get was an ENT MO, you're in ENT theatre, and you're like, actually, I want to do this. I don't want to do that other thing I thought I wanted to do.
Wow.
So you're never on the wrong road. There's lessons to be learned everywhere.
Everything happens for a reason.
There we go.
So we know just from the name what pediatric surgery, we know a little bit about what it is. We know the patient population. We know that you're operating kind of from 0 to 16 years of age. But if you were to explain to somebody in detail what pediatric surgery is all about, give us a rundown of what it is.
Sure. So I don't think it's helpful that students and interns get such little exposure to pediatric surgery, and that's probably where it's a bit of an unknown entity. In my undergrad, we had like a 1-month pediatric surgery block, but the guys at Wits here, from what I've seen of the students I've taken for tuts and things, they don't get any pediatric surgery time. Yeah. They see a bit of it in their peds
couple
block.
Of lectures. And
that's it. So that doesn't help. And I find a lot of people really don't know what pediatric surgery is. I'll try and explain it as best I can, beyond we operate on kids. Because a lot of people operate on kids.
Yeah.
So pediatric surgery, and pediatric surgeons love to say this, is the last kind of true general surgery. So like you said, the age range is quite large. So like from day one of life, from day of birth, up until, it varies, but up until around 16. these days, even before being born, there's fetal surgery that is done as well. So
Yeah, sure.
it goes even earlier
Sorry
than day
to
one of
limit
life.
you.
It's okay. And pretty much we are the general surgeons of kids. We operate in almost every cavity of the body, whereas adults have a urologist, a cardiothoracic surgeon, the general surgeon doing vascular, and then colorectal, and then upper GIT. All of those things are encompassed within pediatric surgery.
Wow. So a pediatric surgeon would actually treat a urological problem more than a urologist or a urologic
So
surgeon.
I mean, there's a bit of overlap. As a urologist, you can then do a fellowship in pediatric urology.
Okay.
But then as a pediatric surgeon, you
Yeah.
can do a fellowship in pediatric urology.
Yeah.
But for example, in the VIT circuit, the vast majority of pediatric urology is managed by pediatric surgeons. I think the places we don't operate are fewer than the places that we do.
Okay.
So I think it would be like brain, face, bone, heart. That's it. That's
Wow.
what we don't touch,
And everything else.
And everything else is our domain.
Wow.
Yeah. And that's really appealing for some people.
Yes.
Some people like the freshness, and
Because general surgery, I mean, even though it's called general surgery, is now very much getting a shrinking territory. As further subspecs develop, we've got head and neck surgeons that do everything head and neck, whereas general surgery used to do that.
Yeah, sure. Yeah, I mean, I think these days a general surgeon who wants to work in a city almost has to be with fellowship in GIT or colorectal or vascular, whatever it may be, in order to have a practice. As you go more peripheral, the true general surgeon is appreciated more. But I think in urban settings, you almost have to be a specialist, a subspecialist. Pediatric surgery is kind of slowly heading that way. And I think if you were to go to the exceptional centers, kind of in the first world, and it's starting here as well, you'll get the colorectal pediatric surgeon, kind of the urological surgeon, and for kids as well.
Do you think we'll ever have like a children's hospital dedicated just to burns or dedicated just to GIT stuff?
It's kind of a hierarchy of needs.
Sure.
I think before we get to that kind of point, there's a lot kind of that needs to be done in the health system before we were to get there. It's not kind of impossible, but at the moment I think it would be unlikely.
Okay.
And it's a relatively small subspec, so you can be a pediatric colorectal surgeon, but it would be better to kind of have a colorectal unit within a pediatric surgery department as opposed to an isolated center.
I get you.
In the States, they do have isolated centers. There's centers that just do hyperspadias, for example, but we're not close to that here, I wouldn't think.
They have both the resources and the larger patient population to work with. Yeah, makes sense.
Exactly. Yeah.
Okay, so what is a day in the life of Dr. Jason Mcmaster look like? How much time do you spend actually in theatre operating on your patients? How much time do you spend in the wards? How much time do you spend in clinic? How is your time divided up?
So I think on average, if I were to just think of it roughly, out of all my awake hours at work, and it varies from hospital to hospital, I'd say 50 to 60% of that time is spent in theatre, which is great. As a surgeon, that's where you want to be. You learn a lot in clinic, and clinic is important, but no one actually likes being in clinic. We want to have our hands busy and we want to be in theatre. So I'd say like 50 to 60% of the time is in theatre, then the rest of the time is divided between clinic and being in the wards. So an average day would be kind of start work between 5 or 6 in the morning, see all the patients under my care in the hospital, and then be ready for a consultant round between 7 and 7:30, and then again walk through all the patients, this time with the consultants, kind of giving a summary of the past 24 hours of this patient's stay in the hospital, and from that you kind of get your work for the day. At most centres, that work's then done by like the MO or the intern. Here at Nelson we don't have, so we'll cover that work at some point during the day. And then 4 days out of 5, theatre starts 8 o'clock sharp, and you'll be in theatre, you hope, until the end of the day, and in between cases run around and do a blood here, do a gas there, put up a drip if there's no one else available to do it. So that's 4 out of 5 days. Then 1 out of 5 days we have clinic. So it's the same story, but instead of starting at 8 in theatre, you start as early as possible in clinic and hopefully finish as early as possible in clinic. You then have calls. A third of my salary is overtime, and that they make me work for my money. At Nelson, it's quite difficult. We do generally more calls than other hospitals just because we have fewer registrars. But on average, you're looking at like, I'd say 2 calls a week, and they're generally like 30-ish hour calls. I'm speaking of Nelson and the other hospitals as well. You start in the morning and you don't end the next morning, you end the next day when your theatre list is finished.
So relative to other surgical disciplines, I mean, you
Mhm.
said up to 60% of your time in theatre, which to me sounds quite high.
Yeah.
How is that relative to other surgical disciplines as a registrar? That seems to compare quite favourably.
Yeah, it is. I think, like I said, it's hospital specific. I know at the Gen there's relatively less time. Their theatre turnaround time is a bit longer. They don't have as many cases done. At Nelson, we're really good at maximising our theatre time. I mean, like, I've never been a registrar in other like surgical units, so I couldn't say definitively. I wouldn't say that it strikes me as significantly more than elsewhere. So I wouldn't say like we're better or worse than other departments, but I'm glad we do get to spend so much time in theatre.
Now, surgeons typically, I mean, you mentioned getting to work at 5 o'clock, typically have very, very busy days.
Yeah.
Typically are up earlier than most other disciplines. A lot
Mhm.
of the physicians only arrive to work at 8 a.m. So
That early, eh?
so would you say that pediatric surgery offers a good lifestyle? I mean, obviously you're now in reg time,
Yeah.
which is always demanding.
Yeah.
But do you see pediatric surgery as better or worse in terms of lifestyle? Is it something that people should take into consideration?
Yeah. So this is such a tricky one, Simon. Like I alluded to earlier, and I think not just because I'm doing it, but I think it would be correct to say pediatric surgery, especially on the VIT circuit, is one of the most like demanding reg times you can do. General surgery, I think, is the same as us, if not a bit worse, maybe a bit better, who knows. But it is exceptionally demanding, and I think it has a reputation for being demanding. I remember even as an intern thinking like, man, these pediatric surgeons are here all the time. And there was a spell here at Nelson Mandela Children's Hospital where I was doing 27 calls in a month for 3 months in a row. So it is exceptionally demanding, and it's not conducive to amazing lifestyle at the moment, I suppose, reg time. But that being said, I think like your listeners, they'll decide for themselves over time what they're looking for out of their career in medicine. Like I said to Melissa when I was in ICU and she said, have you thought about pediatric surgery? I said, do I look like I want to work that hard? And if I could, I'd spend more time at home with my kids. It'd be great. But I've been pulled into this specialty. I believe I belong in this specialty. And that gets you through when you're doing a lot of calls in a month or when you here at 5 o'clock in the morning. Not every day, but you, like I alluded to earlier, don't always trust yourself. You know, you'll feel not everything's going to be smooth sailing, but as long as you keep knowing that I'm on the right path, this is where I belong. I'm not a reg forever. Reg time is 4 or 5 years. Reg time isn't the rest of your life. No one's training to become a registrar. You're training to become a consultant.
Oh, yeah.
As long as you keep that in mind and you can go home at the end of the day and you know that you still want to do the thing that you're doing, you carry on. And I think personally, you need to be brave as well. Like I despise it when people talk about their specialty that they're training in and advise people not to follow it. Like, I'm like, then be brave and call it quits, you know? And my wife and I have said, if I get to the point where I don't love it and I know that maybe I'm on the wrong road, be brave and say, actually, I need to find something else. You know, like I said, it's never too late to change. So yeah, if someone listening to this is like, I want to be a doctor and have a great lifestyle and that's my priority, and that doesn't make you a bad doctor. Everyone has different priorities. Like I wouldn't recommend pediatric surgery necessarily. I wouldn't mind a better lifestyle, but this is where I think I'm meant to be, you know.
Do you have a sense of calling to pediatric surgery now?
Yeah, 100%. Even very early in my MO time, developed a very strong feeling that this is where I'm meant to be. This is what I'm meant to dedicate my life to, like the surgical care of children. In your interview for Reg Time, no matter what you're doing, they'll ask you, why do you want to do this? Whatever it may be, psychiatry, dermatology. Why do you want to do psychiatry? And in pediatric surgery, they're like the rote answers. we've already alluded to a few of them. There's like the massive variation in age, the variation in pathology, all these lovely things, like the last true general surgery, everything's always fresh. Like the anatomy is, that's one that surgeons love. If you're ever interviewing for pediatric surgery, you say the anatomy is pristine, and it's beautiful.
It is, yeah.
Operating on a child is like pristine anatomy. But those are the sum of the parts, and like my desire to do pediatric surgery is much bigger than all of them. And I said so in my interview. I said, like, this is what I feel I'm called to do: work with kids and work with them in theatre. And I was like fortunate enough to find that, and not everyone does. I think I was fortunate that I started something and developed that passion for it while I was in it. Some people are so fortunate as to develop that passion without ever actually being in it. They just know. And some people kind of never find that thing that they're meant to do. So I think I was very fortunate in that regard.
Yeah. So you have alluded a number of times to your wife, and as well as your kids.
Yes.
So if I may be so bold to ask you about your family now. So first of all, I want to ask you about the dynamics of being a very busy registrar,
Yes,
as well as trying to be a loving spouse and a family man. So how do you balance your commitments to your job and to your academics? And how do you offset some of the sacrifices you have to make for your family? How do you make it up to them?
Sure. So I have like a few core values around this kind of topic. And the one is that if I can be an excellent dad, an excellent husband, and an excellent pediatric surgeon, I'm happy. Whether there's room for all those things, I currently think there is, and I hope there continues to be. But that means that you have three things that you're going to be excellent at. I don't have much of a social life. I don't have many friends. I exercise much more infrequently than I should. But I keep those three things kind of center. And that's what I dedicate my existence to. Every waking hour is spent being a good surgeon, or being a good dad, or being a good husband. And I mention those three things separately because that's also one of like the principles that I've found is when I'm at work, I'm a pediatric surgery registrar doing everything I can to collect enough arrows in my quiver that when I finish, I'm excellent.
Very good.
And that's what I spend my time here doing. When I leave here, that finishes, and I'm a dad and I'm a husband. Obviously, there's time at home that you need to spend studying, and that is like allotted time, and we treat that at home like I'm not there. I go to the study, and dad isn't available unless there's an emergency, and then they can call me if I'm on call to help. But yeah, when I'm at home, I'm present. When I'm at work, I'm present. And that doesn't mean I get it right all the time, but that's kind of what we found. We had chatted a little bit about it earlier. Kids complicate things. My oldest boy, John, is 3.5. And if I'm not there, he can't understand why I'm not. We do explain to him, dad is helping other kids and making them better. And very proudly, he says when he's big, he's going to be a doctor and help daddy. I think that means in his mind because he'll get to see me more. But he doesn't understand why I'm not there. Whereas my wife, Liz, she can understand it. She can forgive it. And so oftentimes when I'm at home, if there is an extra moment is spent with the boys as opposed to her. And she's exceptionally understanding. I'm very blessed to have met her and convinced her to marry me because she gets it. Yeah. She knows that this isn't forever, and she knows that one day the boys will understand, but for now they don't.
Do you think that it helps that she saw you through internship and ComServe? Because she's probably been subjected to now 7 years of being a medicine widow, but she's seen those long hours right from junior years.
Yeah,
I would imagine that helps her to kind of contextualize reg time a little bit.
Yeah, I think so. I think two things happened. The first is we got married in my internship. We'd been together for 5 years before I started internship, and she'll tell you my first month of being an intern. Where she didn't see me, she had to have a long think about it. Is this what I want? And she was honest about it. And she said, I'm willing to stick by him. And
It's tough, eh? Because it's not like you're doing anything to spite her or to rob
Of
her
course.
in any sense.
man, I can't believe how gracious my wife is. I apologize almost daily for being like an hour late getting home, or, you know, Angel, I'm so sorry, this emergency case came in. I said I'd be home at 6, I'm only going to be home at 9, whatever it may be. Because I feel really bad, right? Which I
Yeah.
think is normal. And she's never once said, like, I'm not happy about it. Every time she's like, cool,
Wow.
you go for it. And I think that alludes to the second thing that I think happened with her, is that she understands that this is like a calling on my life to be doing what I'm doing. She gets it, and as soon as I got it and told her, she got it, you know, it was like that.
Yeah.
And
Certainly our families do sacrifice a lot
yeah,
in our junior years and in our training years, that hopefully once our careers are a little bit more settled, we can kind of make up to them. But in this time of training, I mean, I've had conversations with registrars who have newborns at home. And imagine, I mean, I don't know when your children are born relative to your reg time, but imagine having to juggle like a baby and Caesar pains and all of that. And your husband is so-called living his dream, living his calling in reg time.
Simon, my second son was born 2 weeks before I started reg time.
Oh, wow.
So my wife has been dealing with a 3.5-year-old.
How many medals have you put on her?
Yeah, no, she's incredible, man. I think what she's found hugely supportive, and this isn't always something you can orchestrate, but we live, I think, 5 minutes away from her parents.
Okay.
And that broader support
having a
has
support
also been
structure,
massive.
absolutely.
You know, that if she is having a tough night, she can phone her mom and be like, Mom, these boys are driving me nuts. Can I leave John, my oldest, with you for the night? You know. And she can then just worry about Luke.
So this is an interesting little rabbit hole we've gone down, but it's all for a reason.
Yeah.
Because what advice would you have to somebody entering into their training years as a registrar, and not just for men but also for the women as well? What kind of things you've mentioned? Supports, which is obviously a great thing, but how should people time their reg time? Is there ever a perfect time? It's so competitive.
There isn't. There isn't. I think it's, you know, like Liz and I discussed having kids. And we're like, are we going to wait till I'm finished my reg time? I'll be 37, you'll be 37. Are we going to start a family when we're almost 40? You know, and that just wasn't on the cards. And you take it in your stride. For some people, managing a family and reg time is too difficult. And I completely get that. So a lot of people kind of put it off. In my experience, it's particularly difficult for women registrars. In the general surgery department at Wits, there's like this mantra of they support mother surgeons, which I think is amazing. I mean, my wife, she also has a job, not in medicine, but she'll often talk about like mom guilt. And I think for a mother surgeon, you really grapple with that.
And as much as we feel some guilt as men being away from our kids, I think it's a different level altogether for mothers.
Yeah, completely. I think there's still this like societal idea that dad goes out and does work and mom looks after kids. And as much as that is changing, I think generally my female colleagues that I've interacted with, not just in pediatric surgery, but generally, feel more of a burden of kind of parental guilt.
Medicine and certainly surgery as well is becoming increasingly female driven. You know?
Yeah.
So when I look at healthcare, I mean, just on a wider level, a lot of our allies, physios, OTs, speech therapists, audiologists, there's a high concentration of female professionals there, and certainly in medicine. And so we have to give special recognition to these moms that are both chasing a very, very difficult career and trying to do what's best for their family.
Yeah, it's very difficult. I mean, and I note in my department, when I started my reg time, I think I was the first male registrar in pediatric surgery in Wits for 5 years.
Wow.
So an exceptionally female-dominated registrar body, some of whom are mothers. So I've seen like firsthand with them the difficulties with it. Like, that being said, everyone's honest with themselves, I would hope. And I think to myself, like, should I have waited? You know, is this too tough? And once you have a kid, you'll be like, not a chance. You know, like, it's just the greatest thing. So everyone makes their decisions for their lives themselves. and everyone can decide, like, do I want to wait? Do I want to have kids during each time, before each time, whatever it may be? There's no right answer.
Yeah.
But I can tell you, you will not regret having your kids and having many of them.
Oh, that's very valuable insights and input. Thank you so much for that. And also, we have to obviously recognize the other side of that same hand is that there will be people who say, you know what, I'm happy to be a pediatric surgeon and help other people's children without having children of my own.
Yeah.
Maybe they choose their patients to be their children. Coming back to your specialty of pediatric surgery, how involved in your practice is instrumentation? Is there special tools for pediatric surgery? I mean, do you use the same laparoscopic tools that you do for adults, or do you have to almost learn a whole new toolkit to be a pediatric surgeon?
So there's a lot of general surgery principles, like the core of being a surgeon, that carries over from adults to kids. I think the first thing to acknowledge with pediatric surgery is we've already talked about the wide array of patient demographics. So you're not going to use the same instrument set you'd use on a day one of life kiddie on your 16-year-old boy with an acute scrotum. So sometimes we use adult sets when our patients approximate adult sizes, and sometimes we use very, very fine instruments, particularly for small kids that need delicate procedures. I talked a little bit earlier about seeing the pediatric surgeons walking around with their box of loops. So oftentimes, if you see us, we'll have this little black and silver box, and then those are our loops, which is like the hallmark of being a pediatric surgeon. When you get yours as a registrar, you're like, now I'm a pediatric surgery registrar. And they're basically like magnifying spectacles that we wear in theatre when we're operating on little ones. So yeah, sometimes the set's the same, oftentimes they're difficult. We also talk about something called your pediatric surgery hands. Generally, we find when general surgeons come across, when we cut with general surgeons, when they're rotating through our department as a general surgery registrar, their hands maybe aren't as fine as ours. We are used to working in small, delicate areas, you know. In trauma and general surgery, they teach, you know, these big, you know, bold movements, you know, big surgeons make big cuts, and in pediatric surgery is very different,
Yeah.
you know. But you acclimatize, and after a small amount of time, a general surgeon finds their pediatric hands. And
some of that just makes sense, like a 5 centimeter incision on a child versus 5 centimeters on a 50-year-old man.
Yeah. I mean, I had been in theatre a lot before I got my loops as a registrar, doing a lot of cutting. And I remember the first time I put them on, I was doing a hernia case with one of the consultants. I put my loops on and I was trying to adjust to like operating with this tiny field of vision that's magnified, and everything out of that kind of field of vision is blurry and out of focus. And I made my skin incision for the hernia, which is like 2 centimeters long. And I think just for muscle memory, I made the incision. And when I saw myself making this cut with my loops, I was like, is that how, you know, rough and imprecise I've been without loops?
Yeah.
I remember it distinctly thinking like, wow. And my first thought was, everyone who's cut with me while they've been wearing loops must think I'm like a Neanderthal, you know? And you have, I'd say, like a 15 by 15 spherical field of view that you operate on with loops, and your hands should stay in that field of view the whole time, you know?
Wow.
So it's small movements, and you find your pediatric
Does it
surgery
affect
hands.
your depth of field? I mean, you obviously have haptic feedback because you're working with your hands, but
Yeah.
does it affect your recognition of depth of field and distance?
So when you get measured for your loops, there's this lady that comes out and does the whole measurement with some machine, and there's like a window, or like your working field, they call it. And I think it's like a 30 centimeter kind of distance away from your eyes, like a field of 30 centimeters, that you tell her, this is where my hands usually are when I operate.
Wow.
And when they make your loops, they make it so that everything within that area is focused. But anything closer, anything further away is out of focus.
It's so interesting as a junior doctor to listen to surgeons speak about their practice, because you get to recognize that there truly is an art form to being a surgeon.
Yeah.
Is there anything that you did to train your hands as a student or a junior doctor? I mean, I've heard of people using their weaker hand to brush their teeth to strengthen up their other hand.
So I'm left-handed, so I think it's, you know, it's tough being left-handed in a right-handed world. Eh?
Absolutely.
Are you also left-handed?
No, I'm right-handed.
I'm sorry.
But somebody who's left-handed described it to me this way. They said, you know, a left-handed person, when they write, they see where they're going, whereas a right-handed person sees where they've been.
Fair enough. So anyway, I think I generally use my right hand more than right-handed people use their left hand. So I don't think I've never brushed my teeth with my right hand to try and get it better. In terms of like being better, I think if you're like a student, like no, you're not tying. As silly as it may be, my old bag had like a million knots all over it because I would borrow a thread from a theatre and just like practice my knot tying with my hands, you know. So simple things like that. But if you're going to be a good surgeon, you'll spend enough time in theatre that you won't need a knot tie outside. But sure, if you want to practice, go for it. I recommend tying your knots. As you get a bit better, there's like laparoscopic training boxes that a few departments have. You can go and practice with those things as well. But there is no surrogate to being in theatre. And I think you mentioned earlier about like choosing your exposure. And as difficult as it may be when it's 5 p.m. and you want to go home and you're a student and you're going to go home and have fun, you know, it's Friday night and your friends are going out, you'll be doing yourself such a service staying a bit longer, not for the sake of staying longer to say like, oh, well, I stayed to 7 p.m. Look what a good student I am. But if you can stay longer and get more exposure, I think it'd be fantastic, you know. And generally when you show yourself to be willing to go that extra step as a student, I found it's rewarded by the doctors you're working under. And maybe if you're just there during the day, you're holding the retractor. But if you want to stay a little bit longer, they'll let you close skin, you know, on the next case. And just it's those small things like that, just spending time in theatre, getting used to your hands, doing those things opposite a surgeon who can say, maybe try this instead.
Yes.
That by the time you get to MO time or the time you get even to your registrar time, you've been in theatre so much that the person you're operating with goes, wow, like look at your hands, they're really good.
Which goes back to something you said as well about being brave. Now, many students don't have the courage to ask, don't have the courage, and junior doctors as well, we don't have the courage to say, do you mind if I do this?
Sure.
You know, as Neanderthal-like as our hands might be, to have a go at closing skin. You know, I think to many students who are doing obstetrics rotation, you know, that's their first exposure to theatre. For many people, and first exposure to really assisting in a meaningful way in theatre. You know, to close the rectus sheath. It's such an easy, like you can't do it wrong.
Well, then you have an incisional hernia, and then you can't do it wrong.
But I mean,
if you're doing it with someone opposite you who knows what they're doing, they're not going to let you do it wrong, right?
Correct.
And I think you're right.
I think that's what I'm trying to say.
Yeah, exactly. I think I'm trying to think how I would react if a student said like, "Can I close skin?" I think everyone takes ownership of their patients, and maybe particularly with kids, I'd first be like, "Well, do you know what you're doing?"
Sure.
You know,
maybe do one suture.
Exactly. So I think the thing that I would suggest that I would respond really well to if a student was in theatre and they said like, "I'm really interested in surgery. You know, I don't want to be a burden, but I would love to be involved." Almost every surgeon would respond well to that. That being said, sometimes you do have to pay your dues and sit and hold the retractor. You know, I've almost fallen asleep many times, not lately, but as an intern holding a retractor at 2 a.m. in a trauma case for Dr. Jennings at Barra. I remember it distinctly because I actually did fall asleep. They were operating on a man's axilla doing a vascular repair, and I was holding the retractor at like 3 a.m. and I literally nodded off and dropped the retractor.
Oh my goodness.
So sometimes you have to pay your dues and hold the retractor. But if you're there, if you're present, if you're engaged, if you're interested and you're asking questions and either overtly saying, "Can I do this?" or like kind of less overtly saying, "I'd love to be involved if you would let me," I think you'll definitely get more reward at the end of the day.
Wonderful.
Yeah.
So what is particularly rewarding about, I'm sure there's so much that's rewarding about pediatric surgery, and you can probably give me an hour-long highlight reel of cases, but for you, what is something that you love doing as a pediatric surgeon? Any cases that when you see them on your list, you're like, oh, I just love doing that procedure?
So I think generally, we'll get to the specific cases now, but I think generally there's so much that I find rewarding about pediatric surgery. Like one, just being around kids all day, man. It's fantastic. When an adult's sick, they like let you know they're sick, you know, they're like miserable, like I don't want to be kids don't know. And unless they are exceptionally ill, they are happy little creatures, you know. And then the second part of that is you're doctor to the patient, but you're also a doctor to the parents. You know, and that's something that I absolutely love, being able to sit down with a parent and draw some drawings and say, this is what's wrong with your child, and this is how we want to fix it, you know.
Sure.
Giving them like a sense of ease, like it's okay, we know what's going on, and we're going to do our best to make sure like the most precious thing in your life is treated as well as
Wow, it
possible.
must be really tough to communicate that to parents who understandably are just so racked with worry and fear for their child.
Yeah.
Is there any phrase or anything that you say that really resonates? Does the fact that you're a father help comfort them?
Yeah. So I think, we do deal with like pediatric trauma. We're also pediatric trauma surgeons as part of the greater scope. And we do deal a lot with pediatric like surgical emergencies. And the thing that I find is true for me, there's like this saying in generally any like emergent field of medicine that you're seeing that person on one of the worst days of their life. Like every person that you interact with at work is having one of the worst days of their life. How would you be treated? How would you want to be treated on one of the worst days of your life? And for those parents, even more so, like I'm seeing that mom or that dad on one of the worst days of their life. Like if I were to think of me, I would stand in front of a train like every day with my boys if I could, like
and let the train run back over you again. And then
yeah, exactly.
Yeah.
And so my kid being sick scares me much more than me being sick.
Wow.
So I'm seeing that parent on the most scared, like terrible day of their life, and I just always remember that. So I think for any doctor seeing a patient who's in an emergent position, just keep that at the back of your mind. This isn't someone you've met at Pick and Pay. This is someone who you're seeing on one of the worst days of their life. Sometimes, like when I feel called to use it, when I can see a parent is like in a particularly tough state, is I say like, if this were my boy, I would be doing the exact same thing to get them better. Like I know what you're going through. I'm a parent too. My boys also had operations. And I'm going to do everything that I would do for my boy to get him better.
Very good.
And I find sometimes that does help. Like I said, it can become like super cliched if you just use it in every case. Every hernia you repair, I'm going to operate on your boy like he's my boy, and it kind of loses the gravitas for me as a surgeon and also for the parent. So in times when I feel that the mom or dad is like particularly in that moment where they could hear that, I think I find it's helpful. I find it's helpful to express.
Yeah. So again, I'm going to come back to ask you what is the most rewarding part, and what are some of the procedures that you just love doing? Some of the surgeries that are really fulfilling at the end of the day.
Sure. Specifically, a lot of people don't enjoy burns, but I really enjoy treating children with burns. I said earlier, I kind of made the decision to apply when I was in the pediatric burns ICU as a medical officer. And I think that's just like stayed with me. The emergent treatment of a child with burns is rewarding, but I find like the reconstructive treatment as well exceptionally rewarding. I was lucky enough with one of the plastic surgeons at Baragwanath last year, I think it was, to do some like full facial grafts for two boys that had facial flame burns to their face. And that was just an incredibly rewarding experience, and I find anything like particularly fine and delicate to be massively rewarding. There's a whole within pediatric urological surgery, there's even a further specialty in hypospadias surgery. A lot of the students that come through clinic have a vague idea of what hypospadias is, but it's basically like a congenital deformity of the penis that is exceptionally difficult to treat. There are over 300 described operations for hypospadias surgery.
Wow, I didn't know that.
Yeah, and anytime there's multiple ways described to treat one thing, no one knows the way to treat it. The disease that has one treatment, everyone knows that treatment works, So hypospadias treatment and surgery is an exceptionally difficult field of pediatric surgery. So much so that in centers in the States, there are surgeons who call themselves hypospadiologists. Wow. That is all they do. They dedicate their life to the treatment of one problem, because that's how much exposure and time and repetition and training you need to get it, right. And I find a surgery like hypospadias surgery, where there's like a reconstruction component to it with like exceptionally delicate work, to be massively rewarding. The trouble with hypospadias surgery is it's hugely rewarding once you finish the operation, and the anaesthetist always looks over and says like, "Oh, that looks beautiful." When you see it 2 weeks later in clinic, it looks less beautiful, and the complications are rife in hypospadias surgery. Wow. And then it can be a bit soul crushing to think everything looked beautiful and
Yeah.
now you've got a fistula or whatever. So
Sure.
yeah, those are like the two areas that I found particularly rewarding. But really, I'm still exploring, and there's so much that I haven't done myself that I've just kind of assisted in.
Which is, I think, is a fair comment, because you're at the
Yeah.
beginning of your age time.
Yeah.
But it's nice to also see that you recognize, like, you're doing good work.
Yeah.
You know,
Yeah.
surgeons are doing God's work and
Definitely.
make a difference in people's life. So pediatric surgery is definitely something that has come along in leaps and bounds in the last 20 or 30 years.
Yeah.
Where do you see the practice and the study of pediatric surgery going, particularly in South Africa, because we're speaking to South African doctors?
Sure. So I think in South Africa, in pediatric surgery, although we like still generalists, I think we are going to see a move towards more subspec units: pediatric colorectal surgery, hepatobiliary surgery, oncology surgery as examples. And I think probably in the next 10 to 20 years, you'll almost, like you do in the States or the UK or Oz or Europe, you need a sub-fellowship. I think that'll probably be the case in South Africa in the next decade or two. So kind of more operating in silos. I think in addition to that, and kind of parallel to that in a way, there's this idea of global surgery, which a few of your listeners may have heard before, and that's really been a huge movement in general surgery, this idea of global surgery, which is, I think, like very, very summarized, is like a pairing of public health and surgery to get the most kind of bang for your buck in surgery for a set population. And that global surgery movement is taking hold in pediatric surgery as well, of figuring out how do we allocate our resources most adequately to help the most patients. And then the same advances in general surgery you would expect, like laparoscopic surgery and minimally invasive surgery are now bearing fruits in pediatric surgery as well. The general surgeon, head of department, in one of the lectures for intermediates kind of alluded to minimally invasive surgery and said we want to make sure we are training world-class surgeons, and part of that is training in minimally invasive surgery. So that's also a huge movement within pediatric surgery as well, that we're seeing more and more minimally invasive surgery. So I think those three arms would probably be like where things are heading.
Yeah.
Subspecs, global surgery, and more minimally invasive surgery.
And I think that's a fantastic foundation to what my next question would be, which is operating in a slightly resource-limited setting like we do in South Africa. Do you think there is anything that we're currently restricted or held back from doing in South Africa relative to other countries in the world with regards to pediatric surgery? Is there something that we're just not getting right? Is there something we could improve in the short or long term?
Yeah. So we are, I think for a little bit maybe, we were behind in minimally invasive surgery. And I think we're now making active steps to catch up. And I can't remember the last time I did an open appendicectomy, for example. That being said, I think like the inverse is true. I think the training in South Africa in pediatric surgery and the exposure you get is vastly superior to even Europe.
That's tremendous to hear.
Yeah, I mean, there's a paper by Zanini et al. That anyone can look up, and they basically compared the logbooks of Europe-trained pediatric surgeons to South Africa-trained pediatric surgeons.
And we compared favorably, I think.
Not favorably. They looked, maybe unprofessional to say, but they looked like amateurish in their numbers.
Wow.
Compared to the numbers that we're doing here. Things that are... I remember that same Zanini et al. Was this consultant who I worked under at Barra, an Italian gentleman who's now back in Italy, in Milan. And the one evening, him and I were on call, and we were closing a gastric perforation for a neonate at like 1 a.m. And I remember him saying to me, like, Jason, back in Milan, this operation would be done by the head of department and the vice head of department. Wow. And he said, here we are at 1 a.m.
Yeah.
He was still a senior registrar at that time, an Italian consultant working here as a senior registrar, and I was a medical officer. And we were there, an MO and a registrar, doing something that in Italy the head of department would be doing.
So we really have incredible opportunities here.
Yeah, our exposure is absolutely incredible.
Which is fantastic to hear, because one of the things that irks me, I'm a South African, not a South Afrikaans.
Sure.
So when I hear of people saying that they want to pursue their studies overseas because they get better exposure or better training, that really irks me, because I feel like those people have a wrong idea of what their training in South Africa is meant to be. So it's so comforting, so encouraging, so exciting to hear that if you want to do pediatric surgery, that South Africa is a great place to not only train but to work and to stay.
Yeah, I mean, there's a reason that our department has so many foreign registrars come and train. You know, the exposure you get here compared to overseas is massive. Like academically, I think we compare favorably. I don't think we're behind in terms of like head knowledge, but in terms of like hand knowledge and practical experience, I think, in my opinion, as a South African, we are far ahead.
Tremendous. Okay, we're reaching towards the end of this interview. Thank you so much for sacrificing so much of your time. I think your answers have been great. They've definitely come from both your head as well as your heart, and that's come through in the interview. If I was to ask you some resources or things that if somebody's interested in pediatric surgery and they want to explore this topic a bit more,
Sure.
do you have any hints or links or tips that they should brush up on?
So I think to get like an idea, you could listen to the Discover Pediatric Surgery podcast. It's a podcast made by Andrew Grieve, who's the head of department here at Nelson Mandela Children's Hospital, and it covers kind of in broad strokes some big topics in pediatric surgery, from biliary atresia, hypertrophic pyloric stenosis, and quite a few others. And that'll give you an idea of like the pathology that we see. I mean, if you're interested but you're unsure, to either try and spend some time in pediatric surgery,
maybe like an elective.
Yeah. So either doing an elective or requesting if you're an intern to be allocated to that department, or if you're beyond that and you kind of applying for MO jobs, think, 6 months of my life isn't a huge amount. Let me go and do pediatric surgery for 6 months and see what it's about. So those would be the recommendations. Yeah, and if you're a student, discover pediatric surgery, get an idea, and then ask to shadow and do some job shadowing at any of the hospitals. Nelson Mandela Children's Hospital will be happy to have you, and get stuck in. Like you're not going to learn a lot standing at the back of the theatre not being involved. Like get stuck in, ask if you can do things, look to help the junior doctors. They will appreciate every little bit of help that they can get, and that'll give you some idea.
Okay, so if I want to just squeeze the last little valuable bit that I can out of this interview.
Okay.
If you were to go back to your junior time as either an intern or a ComServe doctor, maybe even for a student during their clinical rotations, what is something that you learned the hard way that you would love for people to know, just to save them learning something the hard way, save them some pain? What is something you wish you could have done?
Okay, yeah, that is squeezing the last little bit. I'm trying to think if it's something like specific, like don't go and scrub before your consultant scrubs when you're in theatre.
That's a great.
Okay, that's a little tidbit. I think generally though would be like, don't pressure yourself. Like I didn't know what I wanted to do until I found out what I wanted to do. A friend of mine who's finished in neurosurgery in Cape Town knew from second year medical school he was going to be a neurosurgeon. I was always so envious, like he knows. I don't know what I want to do. But you find your home, don't rush it, like get broad experience. And one day you might apply for something and after a month they'd be like, oh wow, I found this is what I want to do. So don't pressurize yourself. Everyone has different kind of ideas of how they're going to spend their medical career. And there's no perfect answer, but everyone finds a home in the end.
And on that point, we're going to leave it there. Thank you so much, Dr. Jason Mcmaster. Thank you for sacrificing some time with your family and with your kids. I hope that this podcast reaches receptive ears and receptive hearts, makes a difference, that people will be challenged, inspired, encouraged, and equipped to make better decisions about their career path. Thank you so much again.
Cool. How many listens did you say Nadia got for trauma?
So far, we're sitting on just under 300.
Okay.
So let's see how far.
Yeah, we can beat that.
That's after a month of listeners. So.
I mean, we're not competitive or anything in pediatric surgery, but I'm sure we'll be. Thanks very much, Simon.
I hope you enjoyed this week's episode as much as I did. For links to any of the articles or the pediatric surgery podcast that Dr. McMaster mentioned, please consult the show notes posted with this episode. If you know of a consultant or senior registrar in a specialty that you would like to be featured on the Dr. Coffee podcast, please get in touch. The podcast's email address is drcoffeeza@gmail.com. That's drcoffeeza with no punctuation marks. We're also on Instagram and YouTube with the username @drcoffeeza. If you've got anything else on your mind, such as a request for additional topics, further information on how to engage with our guests, feedback on the show, or anything else, please get in touch. We'd love to hear from you. Thanks again to the sponsors of this week's episode, FlashMed and the WardWorks app. Don't forget to give them a follow and a like in appreciation of their support. You can find links to their social media pages and websites in the show notes for this episode. The Dr. Coffee podcast is brand new and freshly brewed each week with you in mind. Please consider sharing this episode with fellow junior doctors and medical students in your world who you think would benefit from the content and enjoy. You can also help by posting a picture of your favorite warming beverage on Instagram with the hashtag How'sItBrew, that's brew with an EW at the end, and mentioning @DrCoffeeZA. We'll repost every mention to our story. Thank you so much for your support.